You guys ready? Everyone good?
Yeah,
Let's do it.
Let's do it.
Cool. So thanks again for being here today. We're really excited to talk about physical therapy, excited to talk about your credibility and your history in the entire physical therapy division of health.
Yeah.
Obviously, we're talking a lot about different health topics in our segments, but specifically focusing on physical therapy here today. So
Cool.
Thanks for being on.
No, definitely. Thanks for the invite. It's funny, like, excited to talk about physical therapy. It's like dentistry. Like, no one, I want to go to the dentist. Let's really talk about that. Like,
It's interesting, yeah.
I mean, I think because we're athletes, like we all just,
Yeah.
we've gone through it, so we have a passion for it. We understand how our bodies work and all the things that we've had to deal with over time. So
Totally.
Yeah,
So,
and we'll get into that today. Each one of
Yeah.
us have probably worked with a person in your field in one manner or another because of the fact that we've basically acquired injuries over the course of our...
pushing yourselves, athletes, active. Yeah, totally. So, I mean, for people like you guys, like I would hope a little exciting, as in like, this is super interesting because I push myself. Like if I battle my own injuries, it's like, can you fix this stuff? Like, there's a solution, like how do I go about it? You know what I mean? It's like, that's what we do. Let's get after it.
hell yeah.
Well, now that you say that, and that's what you do, can you talk a little bit about Athlete Restoration Company and what makes your company different than the typical physical therapy facilities around the rest of the country or maybe even the globe?
Yeah, totally. No, I appreciate that question. So the name is definitely unique in that that's who we try to serve. And a lot of people will ask, like, do you only work with pro athletes or college athletes, right? Like, 'cause I'm kind of intimidated to come in. Like, I'm not a pro football player. And it's like actually the meat of our schedule and the meat of the people that we see the most that's all high demand are like the active athletic weekend warrior moms and dads, young professionals, and then people who are in their, aging athlete type of phase of life where they're like, I really want to maintain my mobility and vitality, independence. Like, what does this look like when I become 75 and advance into 80?
Yeah.
Like, because if I'm 65 right now or 62 and I'm running 5Ks or I'm doing this, like, and my hips giving me trouble, it's like, what does that look like 10 years from now? Does that mean I need a hip replacement? It's like, actually, you can avoid that stuff. You might not need it. So anyway, we cater to the active, motivated, and enthusiastic people that want to get better. They want to stay active, and they're super curious and intrigued and interested of like, oh, this is cool. Well, can you help me with my neck too? Or like help with my shoulder, Like, can you help me with all this stuff? So that's what we like to work with. And the clinicians that we've brought on board in our team are motivated and enthusiastic in the same way because we get fulfilled and thrilled with working with people who are motivated and pumped too, versus the people that unfortunately that are in the insurance space, which we'll get into in a minute. Usually those type of patients, they're really nice people, of course. They're great. The practitioners are great too, but they're usually not super the same kind of motivation and stage of walk of life. You know what I mean? Where they're like, I'm just here because my doc told me to.
Yeah.
So imagine like, or like, well, I'm just in here to satisfy my insurance justification so that I can get surgery and an injection like in a month, but I have to do this first to show it doesn't work. Great. Yeah. So you just belittled our entire career.
Yeah.
Well, what am I doing here? Like what?
Yeah.
That sucks, But anyway, so the people that we see that are like, we're out of pocket, right? So they're motivated and pumped. They're going to pay attention. You know what I mean? Like imagine if you were to go see a practitioner that you're, really invested in what you do for your life. And you're like, this is what we do. We're specialists in this. And like, and guess what? This is inflated, of course. Let's say it's $1,000 an hour. Would you show up late? Or would you be like, dude, I'm going to get there early. I'm going to have my notepad and I'm going to pay attention, right? How can I do this in my life? You know what I mean? How can I implement this in my life? So those are the type of people that we that we cater to. And, you attract who you attract who you're with and your personality and your vibe. You know what I mean? Yeah. So that's who we've tried to cater to. So we don't only just treat athletes. Anybody who's active and athletic, like you're an athlete, and we want to maintain your high-level activity and your vitality, independence, and enthusiasm,
So you touched on right there a couple of points regarding the cash pay type of program opposed to insurance-based and how it could really change the direction of the clientele that you deal with, mostly from a mental standpoint of why they're coming in and the why and how the result. Is that a common thing for physical therapists to be cash pay, or is it more of an insurance-based program that you typically see? Why did you structure towards the cash pay thought process?
No, definitely very, very dominated by the insurance in-network type of clinic set up for sure, because insurance runs the world, as you guys know. I can talk all day about this stuff. There's super interesting Joe Rogan podcasts on this I've listened to, and I'm like, my mind was blown, and I'm like, I had no idea how bad, but anyway. But so it totally changes the vibe, the people that would be interested, the mindset coming in, right? It's like, here's a professional, I'm going to be one-on-one for an hour, right? That's another unique factor, is that we're only one-on-one for an hour with everybody. So we spend a lot of hard mental effort on like, let's figure this out, versus half-assing it. You know what I mean? Or like, oh, I got lunch in 20 minutes. We're like, yeah, so good. I'll go over there and do those things. I'll be back in a minute. And it's like, what? Like, nobody wants to be here. No, you're not getting the results you're looking for. Mm-hmm. So I think a unique factor in addition to that is our mindset, as in like, imagine going to a healthcare practitioner place and they actually try hard. Like they actually put some mental effort to like, let's dive into the matter and figure this out, versus like not really caring. And then on top of that, the back end administrative type of support. Imagine you call and you get a phone, you get answered with a human right away, and they actually have a good attitude.
Yeah.
That's a breath of fresh air, versus waiting for 15 minutes. They don't answer. I'm going to give you a call back and you get a robot, and it's like push one for the extension or whatever. And then when you do talk to somebody, they have an attitude, right? That's unfortunately a very common stereotype of healthcare practices. Yeah. It's like, I need help, and you're going to give me an attitude, right? But the reverse, it's like a breath of fresh air. So anyway, we try to embody all that.
As a patient of yours in the past, one thing that I would also say is probably a benefit that I've seen as I would say a problem for many clinicians in other facets, not just physical therapy, but in other fashions, is the duration of your appointment, right? Sometimes a clinician will come in and spend 5 minutes with you and like, here, I'll write you a script. You guys are invested and really take care of a short-term and a long-term approach to getting you to where you want to be. Yeah. Which is not common.
Well, I appreciate that. No, we do try to, that's what we, for sure, we try to invest, like, other small business owners I've talked with in the past, there have been our patients, right? I've been clients of theirs or other things, or like construction or plumbing or like whatever. And then talking to them and being like, does anybody care what they do anymore? Like, does anybody care about their craft or like trying hard? Does anybody try versus just half-at BSing, just like, I just want to make the money and just like move on, But anyway, so we spend an hour, and the first steps, of course, is to like get things feeling better. We try to explain a lot of stuff and dive into the education component, because I think the education is really huge, because the people we work with, they're invested and they are going to do stuff. Like, they're like, what can I not do? What should I do? What exercises, what interventions can I do on my own at home? Right? Versus like, do I have to do this stuff? It's like, hey, my shoulders to hurt. So I'm like, did you do some of the stuff we talked about? I don't even remember what we talked about. I was like, what are we doing? What are we doing here, guys? But anyway, so the cool thing is like with this, like you said, like we try to invest very hard, and we live and die based off our results. Because once we are out of network and we're fee for service, right? We're cash. So on the front end, people are like, why would I do that and pay quadruple the amount, right, of a copay or for free when I could go to this other insurance place for free and see you guys? Like, why, right? Yeah. But so we live and die by the results. Mm-hmm. So that being said, like a lot of people that are functional and active and motivated, enthusiastic, I was saying, the typical standard progression for healthcare is for sure like, I use my Blue Cross Blue Shield or my Humana. That's what you do, right? So they go that route, they don't get better. They don't get the results they're looking for. It's like, I'm still not able to play 3 days a week sand volleyball, right? Go back to the doc, and it's like, well, you don't need to do that to live. Mm-hmm. Why don't you just stop? I have an idea. Just rest for 6 weeks, ice, take some Advil. Just do that. But they're like, I don't want to eat. Yeah, it's deflating, number one. And then number two, it's like, you're going to tell me how to live my life? And then it comes to us, and we're like, awesome, let's get after it. We're going to modify some things. Well, we got to work on your scapula. We got to work on this. We got to work on that. And that's how you're going to hit harder. You're going to jump better, like whatever. And they usually eat that up. And it's like, you're going to not tell me not to do it? That's awesome, Versus like, let's get after it, So I think that's another huge difference.
Agreed.
It's almost like a perfect match of y'all's attitude, because you're right. You look at different industries. People are they're monotone. They're just watching the clock. Yeah. And customers know that when they call in. It's like, this person, you almost want to hang up and try someone else because it's just not what you're looking for. But if you get someone energetic, it's like, let's go, then you're motivated. So you know that's the attitude at your company. And you know that you've got those two customer classes where it's, hey, you're just trying to get back to, quote unquote, live your life. And then your target market, it almost sounds like, is those who, I want to be able to live normally, but then I want to go do all those things I want to do and at a higher level. Right. So they come in, it sounds like you've got the approach for that. So Do you see more where they're almost beating the recovery timelines? Is it more an aggressive approach? Is it just that culmination of perfect match? Like, I guess, what's that story look like when individuals come in and say, hey, it's going to be 6 to 8 weeks?
Right. Yeah, people, great question. So a short answer, speedy recovery for sure. Like, it's expedited totally. Because like I said, a lot of it's the education.
Yeah.
And people don't recognize or acknowledge. It's just ignorance. They don't know yet, right? And I'm not saying they're bad people. They F it up over and over again without knowing what they're doing.
Sure.
It's like, I woke up and it hurts. I'm meant to be in pain forever. It's like, no, you're not. You don't have to be unless you choose to, right? That's another different realm of like the psychology component, which I'm not a psychologist, but there's definitely a lot of the mental component. I think it's very underweighted.
Yeah.
But anyway, so it's expedited for sure. We can educate people. We show them like your sleeping position is contributing to these things lingering, or your training is definitely contributing to this lingering. If you don't set your shoulder, your back, or your hip up for success before you work out with these little mobility interventions or activation recruitment exercises, you're setting it up for failure of compensation patterns to just linger and forever fester. You know what I'm saying? So there's definitely the increased expedited results for sure. And a lot of that's the education.
Yeah.
Yeah. But anyway, the other question was to say was, people usually ask, okay, cool, when can I be 100%? Ultimately, it's up to you. It depends on some factors. And I just did a YouTube video on this of like, or a podcast, the severity, the irritability level, the nature of the injury, right? And the age of the person, right? That sets the stage of like, it's very, very severe and it's been going on for 8 years, right? And I'm 68 years old. That's going to take a little bit longer. We understand that turnover is going to be a little bit slower compared to an 18-year-old athlete who sprained their ankle mildly last week. You know what I'm saying? That's going to be fast, right? Or a muscle strain that was like 2 weeks ago. It's like, dude, you'll be good in a week, right? Yeah. Just don't overdo it right now. Don't overstretch it, right? And do these little things. So the severity, the intensity of the pain, how long it's been going on, the age of that person, that all determines like how long it's going to take to notice significant improvements and changes. You know, so
you almost have to dial them back in a sense where they come in, they've got that attitude, they've got that energy, they want to go 5 days a week. It's like, we don't need that. Like, love it. Or do you kind of run with that?
A little bit of both. It depends.
Yeah.
We definitely get some of the people that are like, all right, so if I do these exercises 10 times, like, it's just a number, like, it's just so you don't forget, right? 10 doesn't matter. It's just 8 to 12, like whatever, right? As long as it doesn't hurt, not making things worse. But like, all right, cool. If I did 100 reps, would that get me better 10 times faster? Like, if I did it every day 10 times, would that increase by tenfold? And it's like, no, there's still, a healing time. Cells and tissue take usually 6 to 8 weeks to have a good foundation of turnover to have a healing potential, right? So not necessarily. But on the other end, right, it's like if you don't F it up continually, you implement some of these things. We're not going to tell you to rest because no one likes to hear that in the boat that we work with usually. It's like, just rest. It's like, I'm tired of resting. I'm like, I'm going to lose my mind here. It's like, I've been resting for 6 weeks. And then they dive in back to 100% again, and it comes back. And they're like, it doesn't work.
Yeah.
It's like, you just got to modify. That's what we say. We just got to modify some stuff right now. I'm not going to tell you to stop. I'm not going to tell you to rest. I'm going to tell you to modify some stuff, right? And use your symptoms as the indicator. As in, like, you did a workout. I want you to work out. I would probably avoid these things right now because if it's vulnerable and it's going to irritate it, I'm pretty confident. So, and what you're telling me. So I would avoid those things. Instead, substitute these type of workouts and exercises instead for your shoulder or your back, like whatever body parts the lit up thing. Modify and implement this instead. And then we can test the water over time and elevate some stuff, try some things. It causes some issues. Okay, we'll back it down, right? And we can course correct in the meantime. We just want to avoid the roller coaster of being like super dramatic. Yeah. Of like, I did a intense, super hardcore workout and it was too much and it lit everything up. You're gonna take steps back. Yep. We have to stop the bleeding at some point, and that's what we're gonna modify. So use your symptoms as the indicator. Is it causing issues right now? Versus the mindset of like, well, I'm gonna do it anyway and push through. We would expect that to cause things to irritate for sure. Okay, is that gonna be helpful? Probably not. All right. Okay. So stay underneath your pain threshold. The next day, that night, how did you feel? The next day, how did you feel? Right. And then use that as like an indicator of like, I think I'm at a good spot. I don't feel too bad. I didn't light things up. I did push myself in some aspects, but I don't feel worse. Okay, cool. Let's run with that.
Nice.
That's what we would run with.
Okay.
Yeah. Does that make sense?
Yeah.
Yeah.
Love that. So, Kyle, obviously, one thing that's pretty noticeable is, we talk about the medical industry, we talk about just physical therapy as a whole, and you've mentioned a few things where essentially you're looking for, or your business is more focused on, hey, how can we really help preventative, but also really help the motivated athlete and or patient, whether they're 60 years old, coming in to get better, right, at the end of the day. So if you could just describe to us some success stories just around advanced manual therapy. And I'm sure there's multiple, obviously being an expert in what you're doing, but could you just share some of maybe the epiphany, some of the great stories you've had?
Yeah, totally. No, good question. So in my opinion, I feel like the main separator for clinicians is their ability to recognize things and differential diagnosis, right? And that comes with humility too, by the way. Like if you see a practitioner, it's like, I've seen this 1,000 times. I know exactly what to do. This is what we do every time for this.
Yeah.
I would be like, I would just question it, right? And myself, I would be like, what makes you feel that way? Did you consider potentially this out here might be a contributing, or this might also be a factor? But anyway, so that comes through humility, in my opinion, and always diving back into like, this was interesting. Let me research this. So anyway, the differentiation and able to recognize some stuff in the competency component, and then the second factor is what you can do with your hands. It's in my opinion, because the manual therapy, I think, is the game-changing separating factor. Joints, you can't alter and affect some joint play and some joint alterations and compensations just with exercise alone. Some changes happen over time for sure, and we can't address and intervene those things that have changed just with exercise alone. That's just what some of the research suggests. So the factor that she's going to change that is the manual therapy, right? So we can mobilize some joints and intervene at the joint level. Soft tissue restriction plays a role with that too. So soft tissue for sure. But the purposeful, what I use is the purposeful discretion. I'm not going to, like, we could do manipulations for sure, but we're not going to rack and crack everything like a bunch of wild cowboys. Like, we're going to pick and purposely choose. Purposely, like, why am I not going to manipulate here, and why am I going to choose to manipulate or mobilize here? That's part of the differentiation. And then be able to execute that with the manual therapy. I think those are the two separating factors. So with that being said, the really cool moments that I live for, that we live for, I think is really cool and fulfilling, is when somebody's been coming in, things haven't been working. They're still in pain, right? If their shoulder, their neck, their knee, their back, their ankle, whatever, right? And we test. We're like, all right, show me the athletic movement that you do that causes the pain, right? If I do shoulder press, that hurts. All right, so show me a shoulder raise, right? Let me do some provocative rotator cuff testing, right? Probably the rotator cuff. It's not that hard to figure that out. The differentiating factor for us is like, why did that happen in the first place? So it's not easy. It's not hard to figure out someone has tendonitis, right? But why? Why is this individual battling this tendonitis? We'll get that in a minute. So we'll do manual therapy stuff, right? We'll intervene just with some manual therapy, some soft tissue stuff in the back end, and then we'll retest the same movement literally 10 minutes later. And they'll raise their arm, we'll do a shoulder press, a provocative test, and it doesn't hurt. Like, I didn't do anything. We didn't change. We didn't even do an exercise. We just did manual therapy. We did the same movement, and they're like, I literally don't feel any pain right now. Wow. It's like, what did you do? That's what we love. We're like, what did you do? That's cool. Because it's like, you can't fake that. Yeah. And there's somebody's maybe already skeptical anyway coming in, right? It's like we intervene with some manual stuff. We retest the same movement you did like literally 10 minutes ago, and now it doesn't hurt. That's a cool buy-in moment. It's like, yo, this is like, this musculoskeletal stuff can be fixed. There is a solution. We didn't even do any exercises yet, right? So imagine if we did do some exercises. Now that things are set up for success, we can stabilize the heck out of stuff and fix the underlying compensation patterns is why it became a problem in the first place, right? That's going to solidify the changes, right? Over a period of 3 weeks, which is like 3 sessions, right? Yeah. Don't F it up in the meantime. It would be unreasonable to think that you wouldn't notice significant improvements, right? And that's, so anyway, the buy-in moments like that, that's a cool moment that we have. And there's plenty of examples I can think of in my head right now, you know, just like, yeah, a simple one. This guy came in with a shoulder rotator cuff. It was just his arm was hurting, right? My shoulder hurts, right? We had to rule out some stuff if it's coming from his neck. Is his rotator cuff actually the painful tissue? Maybe his biceps tendon. That's not that hard to figure that out. But where are we going to intervene? Do some manual therapy stuff. We got his scapula moving better. We did some soft tissue love to his biceps tendon. We probably dry needled his rotator cuff and mobilize his scapula for sure. We can reseat his shoulder joint in a better position. Then it's like, hey, stand up real quick. Let's retest. Stand up. He does the same movement. And it's like, what did you do? Like, yeah, I don't even feel it. I haven't felt like this in like 6 months. It's like, awesome. And let's go from there.
Wow.
I promise you that happens very often.
Listen, I appreciate you being discreet, but Kenny's been complaining about his shoulders for years. He could have just said it was Kenny who came in.
He was one of those guys. I think I needed you for sure, but he's just. I mean, you're a muscular dude, right? He's jacked.
Don't
Don't make his head any bigger than it needs to be.
It's got to sit on those shoulders. You know what I'm saying?
What guy doesn't like hearing that? But like you're a very muscular dude, so like there's definitely some changes that happen, right? And it sets up the shoulder joint for not the best success for reaching overhead and then pushing it, and then usually for ex-athletes who are now in their 30s or 40s, they're like usually it just goes away. Just push through it, but now it's just not going away.
Yeah.
But that's where we have to intervene, But anyway, so yeah, Kenny was one of those dudes, but he did good. Yeah.
We did needling. We did cupping.
Cupping, yeah, I'm a cupping fan.
Yeah.
I usually use I'm sure if y'all have seen Michael Phelps, he had all those rings on his back.
Yeah.
I usually don't cup like that. I'll put some lotion on and we'll cup one cup like across the fascial lines and the functional lines. It sucks, but usually it hurts. Like it doesn't feel good. But I'm like, it's pain with a purpose. It's discomfort with a purpose to make a change. And usually active athletic people are like, I just want the result. Like they just do it. Just get after it, right? Well, it's not going to feel great, but you're going to hate me for the next 45 seconds. But then it's going to make an improvement, right? And if we do this continually, we'll notice changes. Usually they don't want the foo-foo treatment. They're like, I want results. It's like, all right, we'll do it. I'm not going to kill you, but like it's not going to be comfortable, But anyway,
in fact, real quick before we move on, all these guys were in my wedding, but the day before I got married, we did a cupping session, and if you looked under my collar,
we did.
Yeah, I had
oh, I remember that.
I had
because you went golfing. Do you like a bachelor party golf trip too, wasn't it?
probably one of these guys.
Yeah.
But I just had the red from marks from the cupping from my neck to my lat.
To your lat, yeah. We cup the lats a lot on people. Posterior rotator cuff for sure. It just restricts motion. It checks motion that we can loosen up. We can mobilize that stuff. But yeah, I'm a cupping fan.
Yeah.
The reason is because it lifts and separates the tissue, right? So it can break up adhesions. It can break up some fascial interstitial tissue adhesions. It brings blood flow, so it breaks up capillaries. That's why it's like a hematoma. That's where the bruises come from. Okay. It gets really red and purple. Versus scraping, right? Like Graston.
Yeah.
It crushes and scrapes tissue.
Love
Graston. I know.
Really?
People get results from it.
Yeah. It hurts.
It doesn't feel great.
On the ankle. Oof.
Yeah. I'm like in my head, here's a tissue that's already an area that's lit up and vulnerable. Crushing and scraping seems a little aggressive versus lifting and separating the tissue for the benefit of breaking up soft tissue restrictions. That's where my head goes first.
Okay.
Interesting.
Curious just on that. Is that a general consensus, or is that something that you believe in and just your research and obviously years of experience?
I would say more anecdotal, and the research definitely is good on both, and Graston has good research. The interesting thing is, from what they're finding, it usually, the tissue and the joint range of motion that you're looking at retracts within 24 hours.
Wow.
So that's where the exercises come in, right? Where it's if you scrape or cup or soft tissue restrictions, right? That one session alone really isn't going to bring lasting results.
Yeah.
Right. Massage therapy is a great avenue to work on stuff for sure. But unfortunately, we have a lot of people that come with us that have pain from massage therapy. Like, I'm getting massages. That's great. It'd be a great avenue. We got to work on soft tissue restrictions, and they're very valuable. Fixing and getting resolution for a pain issue that might not bring lasting results. And part of that is the corrective exercises, which those choices come from differential diagnosis and recognition of why is this person having shoulder pain the way they are, versus somewhere else in their body, or or their colleague or their friend. And a great way that for the clinicians that we teach. So I'm also part of this fellowship program for manual therapy. It's the American Academy of Orthopedic Manual Physical Therapists, and it's a really cool clinical education and advancement kind of direction that clinicians can go. So I finished mine 7 years ago. 6 years ago, 6.5. And since then, they've asked me to stay on as faculty. So I travel around different places in the country to teach these manual therapy concepts and choices and things you can add to your quiver. toolbox, and then the differential diagnosis as like the purposeful discretion. But the question we ask those clinicians and the clinicians we mentor is like two really. Okay, here's a baseball player that has anterior shoulder pain, right? It's not that hard to figure out if he's a young, flexible dude, right, kid, and or teenager, right, early 20s maybe. It's probably the biceps tendon, okay? Anterior shoulder pain, the long head of your bicep is a very small rope-like tendon that has a very close relationship to your rotator cuff. And it's an easy site for getting lit up if it's put under stress and strain constantly, okay? And the anterior capsule, and you have nerves all up in that area, right? So it's not hard to figure out that the biceps tendon is the angry tissue. Cool. They want to know like what hurts. This is the biceps tendon. Okay, cool. How are we going to fix it though, right? And if a practitioner or a clinician said, "Oh, it's just overuse," they just need to rest. It's like that is a cop out. And the reason why I asked that is, here's an 18, 19-year-old baseball player on a team. The team of baseball players. Is this kid just throwing 50% more than everybody else volume-wise? Everybody else is throwing. So why is Timmy getting this biceps tendon pain and all of his friends aren't? He's got to be doing something different. If it was an overuse problem, then wouldn't everybody have tendonitis come 3 months into the season just from throwing too much? Problem solved, rest and take Advil and ice. It's not the case, because there's plenty of them that have no pain. They're fully fine. Right. So then what is Timmy doing different? Something in his mechanics, right? I'm not a baseball pro or pitching pro, but there's something I am biomechanics in pain. That's what I do. So there's got to be something biomechanically he's doing something different. The core plays a role with that. Lead hip internal rotation plays with that. His external range of motion in his shoulder, his scapula, his T-spine, all those things play factors. And we can differentiate and figure out what he's doing differently that's causing the biceps to overcompensate. And that's where the painful tissue is. That's not the problem. The angry tissue isn't the problem. It's a victim. It's getting overwhelmed and overworked.
That's fair.
Right? So with that being said, then, if we're going to dedicate and direct all of our treatment to that lit up tendon, it's not solving the problem. Yeah. Because it's not the problem. It's just the fire alarm. The analogy we give is like, imagine there's a fire going on and the fire alarm's blaring. That's the biceps tendon. Okay, cool. I have an idea. Let's duct tape a pillow over the fire alarm so it makes less noise. Is that going to solve the fire? Probably not. What's going to prevent the fire from stopping and from going further, and intensifying? Yeah. Why not just put the fire out?
That's a good point.
Right.
It's a good analogy.
I appreciate that, because you were throwing a lot of big words there. I was trying to follow, and then he goes, "Hey man, there's a fire alarm. The fire alarm is not the problem. Don't try to fix it." I'm like, "Okay, good, got it."
There you go. My bad.
No, you're great.
Yeah, totally. Ask questions like my bad. Yeah, good. Just reel me in. All right.
You're good. You're good. It's actually funny you said the victim piece and then you gave the analogy, because I literally was just listening to one of your podcasts and you made this comment.
Oh yeah.
And you were kind of making the point that a lot of times athletes, they compensate to get the job done.
Yeah.
So they're doing something different, even though they're doing the same action as everyone else. But that compensation factor is basically going to end up being the root cause, and you have to try to identify what that is.
Exactly.
But I do have a different question. You've piqued my interest as we were talking about the cupping and the Graston and all those kind of things.
Yeah.
You're probably seeing a lot of stuff is coming to market on all these different tools like the percussion massage machines. They're actually I'm seeing cupping machines that are coming out that are just like battery operated. Yeah. It's kind of crazy what they do. As you guys are going through and exploring the tools that are outside, are you suggesting some of your clients for long term and other things that maybe just based off of the type of athletics that they're interested in? Yeah. Are you prescribing them some of these tools and kind of?
Yeah, good question.
Yeah.
Or is it really something that should be done by a professional? Or where's the line, kind of?
I know. The tough thing is, I don't hate those things, right? Mm-hmm. It's not going to hurt anybody, right? Unless they overdo it, you know what I mean? And that's where we gauge, like, is this a that's very zealous individual? It's gonna like, dude, you're gonna overtreat it. You're gonna light stuff up. There's a line there. Usually, no, we don't really prescribe that stuff. I mean, we would if they're very interested and into it, then we will like show them like hit this area. The reason is because they usually don't do it right. Mm-hmm. So we don't want to like cause a problem. We don't want motivation and enthusiasm to cause an overuse injury or an overuse problem. You know what I mean? I say that with a lot of my athletes. It's personality differences, right? We have a lot of athletes in the past that I've worked with that have chronic like knee pain after a surgery, we usually don't see post-op because they're going to go with their insurance and they get the foo-foo treatment the first 6 weeks anyway, right? Like you can get that, we can get both, you know what I mean? They come see us simultaneously, but anyway, 8 months in after their surgery, ACL as an example, they're still battling knee tendonitis, right?
Sure are. Still
It's-
10 years later, still battling.
That's not an uncommon thing by any means. It's usually because they didn't address some of the compensation issues of like muscle strength, and it's really a recruitment problem. It's like a neuromuscular recruitment issue, not like a strength output problem, and a joint mobility problem, and then the mechanical problem, the mechanics, like their coordination of movement. You know what I mean? But anyway, in those moments, some of those athletes, there's two types. There's the people that aren't doing enough and they need to step it up. Like, you need to do more, right? And we'll call them out and be like, you need to do more of this, dude. I can tell you're not doing your homework. Do you want to play basketball or not, right? The second one is like, we need to reel you back, you know? And that's where we say, like, we don't want good intentions and enthusiasm to lead to an overuse injury. And they're just doing constantly too much. And they're usually in the mindset that I was kind of in, which is like, I'm falling back. If I don't continue, I'm getting outworked. I'm getting outpaced. I got to get after it, you know? I can't take a week off. It's like, you know who takes weeks off sometimes? Is LeBron, Steph Curry. Sometimes I got to take a back seat.
Yeah.
You know,
Yeah.
sometimes you got to shut down. But anyway, so to answer your question concisely, usually not. They usually don't. I wouldn't be confident they would do it right and hit the right things. I would rather hit pretty purposefully. If they're already into it, then I'll show them and I suggest some stuff. You know, but they're just soft. They're just avenues to work out some soft tissue restrictions and knots and soreness. You know what I mean?
And when I kind of talk about like recovery tools too, I mean, there's a huge market for that. I'm a huge foam roller person.
Yeah.
I love it.
Yeah.
I think they're great.
That's the number reason why I would suggest it. I would be like, do you like it? Okay, do it.
So,
You know?
I guess my question really is around like is it I guess, should people be looking for the quick fix? It's almost like I go to a chiropractor, and I've always heard the term that they're crack doctors. You know, you kind of get that instant relief.
Yeah.
Like, I just foam rolled my back. I feel good. I can get my workout in, whatever.
Yeah.
Or is it just better to not think about the tool, but think about the movement pattern and try to do the mobility routine and make sure you're prepping yourself to do the act, not try to use the tool as the quick fix.
As a savior, yeah.
Yeah.
Yeah, totally. So usually it seems like the root cause of non-traumatic pain and issues for active people is from repetitive micro trauma, micro injuries, or that happen, little things over many, many, many episodes.
And compounds.
So it compounds. Repeated movements that cause the same things to happen over and over and over again, not knowing yet. And imagine like someone in their 20s, they're super young, resilient, and healthy. They don't really feel stuff, and then it goes away.
Yeah.
But then they become 35, and it's like, this isn't going away. This is lasting way longer than I remember. You know, like, WTF, bro, it's not getting better. Well, you're also older, and the same things have been ingrained in these in this soft tissue instead of the joints for years and years and years. So it's repeated movements. And then prolonged postures is the other position. So, like, prolonged postures yield.
Everyone pull back right now.
When I say that, everyone
Scapula back.
Yeah, exactly. Everyone sits upright. Prolonged postures is the second component that, like, why did this hurt out of nowhere? Like, I didn't get a car accident. I didn't fall down the stairs. I didn't sprain my ankle, but all of a sudden my knee hurts or my back has been bothering me. I don't know. I tweaked something. How long's it been going on? Oh, man, probably like 6 months. And now it's just progressively more noticeable. That's usually our bread and butter. That's what we work with. That usually comes from repetitive movements and micro injuries or micro trauma over many, many, many episodes that just now the straw that brought the camel's back, right? No pun intended. Or prolonged postures that facilitate some of the same changes. And the most influential prolonged posture is sleeping. Because we sleep. How many days a week do you sleep? 7. For hopefully 8 hours, right? So the positions that we put
He's our non-sleeper.
Oh, really? You're one of those?
For 2 hours.
I don't know how they do. How do you guys do that, man?
It's not by
I don't
choice.
know.
Johnny, what time did you wake up this morning?
Let's not talk about that.
Oh, come on.
But yeah, so like we sleep 7 days a week, and hopefully 6 to 8 hours, 9 hours. That's a lot of added potential irritation or setup for failure that might contribute to issues, or maybe should cause more irritation and problems. You know. So anyway, yeah. So it seems like for long-term fixes for non-traumatic pain that, like, it just came out of nowhere, and I don't know why this hurts. We have to find out what the compensation patterns are and the movement system impairment is, the MSI. That's what we usually go with. And that's usually a combination of mobility disparities in the neighboring joints and muscle recruitment and activation disparities in the neighboring joint. So if some things are very, very dominant and active and you do something challenging over and over and over again, what's the first things that are going to contribute to turn on to help? The very strong dominant guys with the muscles, not the dormant, less active, less recruitable guys, right? Mm-hmm. So imagine for like knee tendonitis, right? What's going to get broken down and irritated faster? The overtime workers that don't get any rest, or the ones that are on welfare and don't really work? The ones that overwork and go overtime constantly. That's your biceps tendon, your patellar tendon, your knee tendonitis, all that stuff. Does that make sense? Mm-hmm. Or like the low back spasms. So it's like, why is that happening in the first place? We have to fix that. The soft tissue tools and stuff can definitely settle things down and get you, if you're like tight and sore in an area, right? Then, and you're not like battling an issue, great avenue. I'm not going to tell you not to foam roll, right? Or use a Theragun or something like that, or Hypervolt. And then same thing with a chiropractor. So like, it has this place in medicine just like anything does. And the number one thing that I would ask is like, do you like it? Okay, then it's not going to hurt you, right? If you're battling something that's been going on for a long time and going the same approach, but you're not noticing results, if nothing changes, nothing changes, which is the way anything is, unfortunately. So that means that something's being missed. We have to find a different avenue or a brainstorm and differentially diagnose like what's going on and why aren't you getting results then? Maybe we need to intervene in a different way. You know what I mean? That's the route I would go to be politically correct.
I'm having a lot of aha moments over here.
Yeah. But anyway, so it's interesting. Like, I'm not knocking on any professions or anything like that, because there's definitely physical therapists that people are like, I've been seeing my PT for 8 years, and you know, he keeps my shoulder or she keeps my shoulder good. Or I've been seeing my chiro for 15 years, and that's the reason why I'm able to do the thing I'm able to do. But it still hurts. I'm like, dude, it takes 6 weeks to feel improvements, right? Like 3 weeks. You should feel like a noticeable improvement after 4 visits. For like that's what we expect. Interesting. Okay. As in, like, I do feel improvement. Yeah, it's not hurting as bad. I'm not able to go 100% yet, but I do notice from prior that like I'm able to do some stuff and it doesn't hurt as bad. We're on the right track. Cool. Nice. Let's continue this trajectory versus course correcting. You know what I mean? Mm-hmm. Versus like it's been 15 years and my back feels the same, but it allows me to do things I want to do. I would question that. You know, like let's investigate some other things. You know.
Interesting.
Just want to confirm. So you said if you identify the root cause and you believe where it's coming from, roughly 3 to 4 weeks, there should be some type of improvement.
Yeah.
Interesting.
So, and here's the reason why I say that. So like, some people who they're otherwise healthy, as in like they don't have other comorbidities, right? They don't have red flag signs and symptoms. Red flags being like underlying diagnoses that we're missing, right? One of the biggest campaigns, because physical therapy is a pretty new autonomous profession. It used to be in like the 80s, 90s, and 80s and 90s a bachelor's degree, and then you worked under the scope of a physician, of a doc. It's like, hey, I just want you to show them these exercises real quick, right? And then they go, we're like, there's like some science behind this. Then it advanced into a master's degree, and I got a little more autonomy, which of course in the realm of money and power and ego, which everybody, you know, that's in every field, was resistance. Like, you don't need to do that. Yeah, this is easy. It's an ancillary service, which it was. It was. And they were getting more sciencey behind it. And they're like, let's advance it to a doctorate degree where we can almost take the role of like a primary care provider for musculoskeletal things that's under our scope. Right? I'm not a cardiologist. I'm not a neurologist by any means. I'm not a medical doctor. I'm a physical therapist. I'm the first one to say that. I'm not going to misrepresent myself and call myself something I'm not, right? But for the world of musculoskeletal issues and biomechanics and pain from musculoskeletal issues, dude, that's our bread and butter. That's what we can get. And we might be able to save you a visit to the primary doc, to the orthopedic, to the x-ray, to the MRI, to the injection, and then the 5th surgery. Yep. Maybe, right? But anyway, so with that being said, it was a bachelor's and a master's. They advanced to the doctorate degree. And there was a lot of resistance and like, this is degree inflation. You don't need that. You're still under the scope of these docs, which was at the beginning still true. And now it's more autonomous, right?
Interesting.
So with what you're saying, so it's a bold statement. You can get somebody better in 4 visits. It's like, of course I'm not going to get somebody 100% better in 4, but we should notice improvements. Yeah. Meaning that like we're on the right track and we're intervening the right way. So how can you be confident then that this person coming in with left shoulder pain it's not coming from a heart issue. How do you know it's not cardiovascular? One of these big campaign, there was a magazine article back in like the early 2000s, this orthopedic doc group who was feeling threatened by the advancement of sports physical therapy profession. A magazine article. It was nuts. And it was like this person bending over with pain. And at the top, it was like, how can you see the underlying cancer in this person's back pain?
Jeez.
So can't a physical therapist. And I was like, whoa, there was some steam after that, right?
Yeah.
Wow.
Nobody can see that unless you have imaging. That's the gold standard, right? The argument is that like, well, the docs will be able to recognize and differentially diagnose, like, this smells different. My brain is automatically going towards this might be something underlying we're missing. Let's get some imaging and testing and refer you out. Whereas a physical therapist be like, let's do some hamstring stretches to fix. And all the while they have multiple myeloma on their low back, like a cancer thing in their back, or a cardiovascular issue in their heart, and they're referring pain to the left shoulder. That looks musculoskeletal, but it's actually a heart issue. So how can a physical therapist know that, right? It's red flag questions and red flag screening that we would then be like, this doesn't smell right. Let's refer you out to a cardiologist, to a doc. You know what I'm saying? Let's get some imaging to rule things out. We would never be like, I think this is a cardiovascular. You have left ventricular fibrillation, you know, like our issue, or, you know, a heart murmur. That's not what we do. I'm not going to know that. But if some of the red flag question that we can go through, be like, this doesn't smell right. This is outside my scope, dude. Let's refer you out to a doc and get some further testing, because I don't think this smells like a musculoskeletal rooted pain problem. Does that make sense?
Yeah.
So to answer your question, if somebody, like, we should see improvements in 3 to 4 visits, right? For sure. As long as it's a musculoskeletal driven problem, that's not an underlying sinister pathology we're missing, like a heart problem, or rheumatoid arthritis issue, right? Or a tumor, an oncology problem. We can't fix that, right? We got to get back to imaging and get some other refer out and stuff. You know what I'm saying? So if it is musculoskeletal rooted, the person's otherwise healthy, like they don't have a bunch of comorbidities that's going to limit their healing potential. They're not a crazy smoker. They drink a bunch, and they're 68 years old, and they're morbidly obese. They have type 2 diabetes, congestive heart failure. They smoke, drink, and they also have a heart issue. They're going to be a little challenging of like noticing results. You know what I'm saying? Quickly. And that would be like, we could still fix your shoulder pain. It's just going to take longer. You know what I mean? But anyway, I hope that answers your question.
No, that's a great perspective. That's really good stuff there.
I kind of want to take this into a future state thought process.
Okay.
Obviously, as someone that's so enthusiastic as yourself and wanting to help driven athletes, I would assume that you're probably eager to learn more, and you're looking at different innovations that are happening within your field. I actually remember on one of your podcasts you mentioned about the fluid that's in the joints and how you can reactivate that over a very long period of time. Seems like a very innovative practice. I know you kind of mentioned how you might get a little flack about that in that episode, because that's the alternative to a knee replacement, which actually Ryan's wife just got a knee replacement pretty early on.
Your wife got a knee replacement?
Yeah.
So I was going to ask you, with the age range of clients that you see, what's the earliest you've ever seen someone that you've worked with someone for a knee replacement?
Oh, man. There was a guy that, this is back in Houston, he had a gunshot wound at his knee.
Okay, all right.
So,
fair.
That's a one-off.
Fair, all right. And how old was he?
Yeah, he was like early 20s,
All right.
mid-20s.
Fine, we'll throw that one out. Well, she was 30.
But that's not the it's different.
She was 30 when she got hers replaced. She just
my
had
gosh.
chronic knee issues at the joint. Just it didn't sit properly. She played indoor volleyball, so all the jumping didn't help. But at 15, her doctor told her, yeah, your knee's about 50. You're going to get it replaced before you're 30. And sure enough, she just had it done in November.
Okay.
But, we're in the room post-surgery. Everyone's got about 50 years on us. Then we go to the first PT, and all she keeps hearing is, wow, you're the youngest, yada, yada, yada.
That is the young, for sure.
But it was nerve-wracking because then you're thinking, you're 30 years old. Like, we went back and forth on, should we do this, should we not?
Yeah.
But it was all about removing the pain. And now, like, she's doing her rehab. She's doing leg extensions. Her knee replacement, she's firing off great. Her quote-unquote good knee that has similar problems, she can't even because it's grinding. It's just bone on bone. So
yeah, I hear that all the time. So like bone on bone, the bone on bone thing. So yeah, that's definitely, to answer your question, that's definitely the youngest I've ever heard. I'm sure that like The great thing is that she feels significantly better.
Yeah.
Cool. We would just go from there and crush stability and strength and minimizing any compensation patterns for the best longevity possible. Totally. I wouldn't. So I'm sure the docs talked about it. Like, they're usually a shelf life of the prosthetics they put in there.
Yeah.
And it depends. You know what I mean? But I mean, max 25 years, something like that, you know? So a revision probably is in the future if she's this young. That's why they were like, oh, wait till you're 60 because then like you'll be dead before you need a revision. You know what I mean? Could you imagine talking to somebody like that? Like, in a long enough. Yeah. Well, like, that's not like, it is what it is.
Right.
Like, we're mortal human beings. Like, on a long enough time horizon, we're going to be dead. But anyway, that's definitely the youngest. There's a life shelf on those things usually, so revision might be in the future. But to answer your question, to go off of what y'all were saying, so I hear bone on bone very often. And that it's not the end all be all, as in like, well, then we're effed. I'm effed until I get a replacement.
Yeah.
So I'll just meander around and just live with it until I get a replacement. That's actually not the case, as in like, and this is also the psychology component, which I'm not a professional psychologist by any means. But I know that we can't separate the mind from the body, and there's a ton of interplay between the psychological component and physical pain, right? Somatosensory pain and psychosomatic pain. There's been proven that like there is emotional-based pain. So we also have to have a delicate dance between that too. I'm not saying your wife's like that. I'm just saying in general. This is a part of the conversation, but that's something we have to consider.
Sure.
Right. So that's going to dictate my approach and some of my talking points with certain patients. You know what I mean? It's not always black and white, as in like you have a rotator cuff problem and then we need to fix the rotator cuff. Yeah. Orthopedic surgeons are very black and white. We call it like patho-anatomical. There's a pathology. There's an issue of the anatomy. So solution, let's fix the anatomy, and that will fix the problem. Not always the case.
Right.
There's plenty of people that have had disectomies, and they have pain on the other side of their back afterwards. Like they get a lumbar surgery, and their pain switches sides. And they look at the image on the afterwards, like, your back looks great. This doesn't make any sense. You should be fine, right? But they still have pain. Explain that. Okay, it's because the structure doesn't always dictate symptoms. The structure of somebody's knee and the bone-on-bone structure, whatever, doesn't dictate what the progression is going to be like or their symptoms currently. Because there's been plenty of people that have very arthritic-looking knees that are like, I've seen knees that don't look great. People that are in like their mid-70s, and she's like, it doesn't hurt. I'm just not strong enough to go downstairs or upstairs and stuff. I remember this one lady in particular. She had like a huge valgus deformity, like it was bent inwards and sideways, like knock-kneed, right? One knee. And it was crunchy, and it didn't sound good. She was limited range of motion. Like, my knee doesn't hurt, though. So we were doing a bunch of things and exercise. It doesn't hurt. It's just challenging because I'm not strong, but I just need to get improved strength and for my life and independence. I was like, this is a classic exhibit A. It's very interesting. The other thing I was going to say with orthopedic surgeons they're so smart. They deserve a ton of respect. They, like, in my opinion, med school, residency, fellowship is probably like the hardest academic trajectory anybody could take. It takes a ton of respect, hard work. They get pounded. But they have their diagnoses. They have their box of window of perspective and diagnoses, right? And with that being said, not everything is patho-anatomical. So if somebody is battling knee crunchiness and irritation of their knee when they do jumping and stuff like that, and they were a previous athlete, I've heard a lot of times they come back from a doc visit and they had an image, and the doc says, you have the back of a 70-year-old, you should be in more pain than you are. I'm like, what the fuck? Like, so my like, why would you say that, man? Like, that will help nothing.
Yeah.
So I'm like, oh. But you have you get paid when you have surgery. Oh my gosh. You get paid with injections. The more MRIs you refer, there's an incentive with that. Unfortunately, the ethics, I can't not neglect that plays a role, right? I'm not saying your doc's doing this. I'm saying in generalities. Or like, man, I was like, okay, well, hey, I have this guy telling me that's in a white coat. He's super smart. He's a surgeon. And he's wearing a white coat that my back looks bad. And I have pain. And clearly on this image, you can see the herniated disc. So let's schedule surgery next week. So I scheduled surgery and had the surgery, right? Or my bone on bone in my knee. Let's have a knee replacement. As long as your knee's effed up, you're going to be effed up. So until you get a knee replacement, you're effed.
At the end of the day, they don't get a paycheck for turning people away. That's my gripe with it.
Yeah.
Unfortunately, every profession's like that. And as an example, imagine like psychologists, right? Mental health counselors. They have a mortgage and they have bills.
Sure do.
Right? So like would it be a benefit for these professionals to solve all their problems to have their clients never come back again? And they get paid session by session? I don't know, right? We're in the same boat too. Like someone could argue the same thing with us, right? It is a business. But anyway, with that being said, I would always question and get second opinions, right? You can always do that. Sure. So the bone-on-bone thing, and this is the podcast I was talking about. All right, so synovial fluid, that's the fluid you're talking about. Synovial fluid is the lubrication and nutrients of a joint. So the articular cartilage, which is the cartilage where if that gets worn down, that's where the bone-on-bone suggestion comes in play. The cartilage does not have a vascular innervation, and it doesn't have a neural innervation. So there's no blood vessels that go to innervate your cartilage, and there's no nerves that innervate your cartilage. So that then suggests they can't heal, right? The more blood flow available, the more potential for something to heal. So a muscle strain, dude, those things heal up quick. Yeah. There's a ton of blood innervation for that, all right? Cartilage has very, very, very low or none blood innervation. Mm-hmm. So the thought was always it can't heal then. So arthritis is a progressively getting worse issue that won't improve. It's like as soon as you hit a level, it goes down. It can't go up. There's a ceiling forever. And then it goes down again, and it's a progressively worsening issue. Mm-hmm. I'm just saying there are some research articles out there that have found improvements in articular cartilage vitality, brilliance, and thickness. Mm-hmm. On the imaging, they call it like brilliance or like the signaling in thickness. And one of the studies I was referencing is like they were doing this test. It was an 11-year study of these dogs, these beagles, that they had in a control group that they just were normal dogs and they lived their lives. And then they had this experimental group. They put a double their weight weighted vest, and they had them run 7 miles, 5 days a week for 11 years. Right? It's like running's bad for you. You're going to break down your joints. There's a certain life shelf of someone's joints. And the more you run, the earlier you're going to have arthritis. So yeah, I mean, you want to run and look good, look good in the bathing suit, but then at the same time, you don't want to break down your joints. Mm-hmm. Apparently that's not true based on the empirical evidence that I'm just referencing. It's not me. It's these other people that are researchers. Mm-hmm. This was up for a Nobel Prize, by the way. Wow. They didn't win. It was in the running. You know what I'm saying? It was in that conversation talk. Wow. So they, at the end of the 11-year study, they sacrificed these beagles. That's where the ethics come in. It was like, oh my God, I know. But they got really good information. Of that control group that didn't do anything, a dog that's played normally, and then the experimental group, double weighted vest, 7 miles a day, 11 years, you would expect their knee cartilage to be broken down. Yeah. So they sacrificed the dogs, they opened up their knees, and they did investigative studies. The control group of dogs had thinner, more brittle cartilage, and the running experimental group had thicker, more vibrant and brilliant cartilage. Wow. It's like, explain that, right? I don't know, right? Well, it may be, then they're talking about mechanics, the synovial fluid and the compression of their joints stimulates your body to adapt to it. And if it's not a irritating and overwhelming stressor, and adaptation of breakdown will occur, but rather it's like a healthy compression that your body will adapt to that causes, we would surmise, underlying subchondral bone that grows forward up through the cartilage, and it generates it from the bottom up over many, many, many months and years of time, right? Wow. So somebody that's betting, so that's what they're suggesting. That's what the article and research suggests. So I'm like, oh, this is crazy. So that the term motions lotion that we use all the time, your synovial fluid is triggered to be produced when you feel friction, when the joint feels friction on itself and pressure. Because it's like, we need to lubricate here. And that's where they get its nutrition as well. It's nutrients. So what they're suggesting is intermittent compression of your joints, which is like resistance training, right? Not so much where it's like overwhelming and too much, because that can cause an issue. Just like water, you can drown in water. You can drink yourself too much water. Too much weightlifting there's a detriment to that, of course. But some, on purpose, intermittently with an appropriate amount of compression and an appropriate amount of stress over many, many years. I'm talking like a minimum of 12 months, 2 years, 3 years, where every time you work out, you leave and you're like, my knee doesn't hurt worse. Actually, it feels looser. Keep that trajectory over years where your main goal is to not hurt after you work out. What they're suggesting is the cartilage would be improved. Nuts, right?
That's
I just had an aha because like I tore my ACL 10 years ago.
Okay.
And we talked about overcompensation. So I tore my right knee.
Yeah.
And my left knee my right knee, excuse me, the one I tore. To this day, if I am inactive, it will just get more sore and more stiff versus me going and continuously working out. So it's all kind of believe in the whole bugle thing here. Like just keep it going and it's going to strengthen in that inactivity. I'm talking like, maybe a couple weeks, a month. Yeah. And I'm like, I don't understand why it's hurting. I haven't freaking done anything. And then I go do stuff and it's like, damn, this like it's feeling back to normal. Yeah. So
sounds like use it or lose it kind of.
Oh,
really?
Yeah.
David Goggins mentality right there.
Yeah.
Like,
Yeah. So he's
We're not saying run 7 hours straight.
Extraordinary.
He's super intense. I love his mindset and stuff for sure. Yeah. But yeah, so like if you don't use it, you lose it. It's totally true. But with that being said, that sometimes can deter people like, well, I'm too far gone.
Right.
Yep.
It's not true. Like you're going to make improvements as you just start. Like I'm at like, as an example, like smoking, right? It's like as soon as you stop smoking, like within 3 weeks, like noticeable tissue perfusion and oxygen delivery has been noticed in the research, which is insane, right? Just it's never too late to stop or to start doing some stuff purposefully. The main question the main thing that I would present with is like, just don't make it hurt every time you exercise. That's a great indicator. So for patients that see us, they're like, my knee hurts, been battling an issue for a while, and every time I try to work out, it hurts, right? We definitely like modify some things, modify the intensity, modify your expectations. It's going to take some time to settle things down, and then we can progress and intervene appropriately. And in the meantime, let's intervene some of the compensation issues. Like that's your workout, is working the compensation issues. And then if you want a six-pack or bigger biceps, then do the auxiliary work stuff afterwards, totally, right? As long as it's not causing more pain, right? But let's work on these compensation issues in the meantime and exercise and work out. And I'm very confident that people will be like, my knee just feels better. It just feels looser, Right, totally. So what I would also ask people that like yourself, it's like, I didn't do anything and it hurts. You're also walking, you're sleeping, you're picking up your dog, your kids, you're getting in and out of your car, you're pivoting out of your car, you're walking upstairs. And if there are underlying compensations, right, they're minor, super minute stuff, but it plays a role. Because how many steps do we take a day? That's 10,000 reps. That's a lot of reps that can maybe ingrain and reinforce issues, but then also just like irritate stuff a little bit. And that compounds and adds up. And it's like, well, now it hurts and I don't want to exercise because it hurts. Right. So then it's like you try once and it hurts again. It's like, well, I'm not meant to work out. I'm effed.
That's it. Too far gone.
So we just got to like intervene with some stuff. That's where the manual therapy comes in. If we can set the joints up for success to move better and it doesn't hurt with doing these little things, right? Then it helps to encourage and reinforce like, oh, I can be okay. Yeah. Right. So at the meantime, resetting some mental expectations of like redefine right now what you call a workout. This is your workout. Right. As ex-athletes, I was the same boat where I was like, if I don't power clean, squat, and bench, do weighted dips, I'm not actually working out. Right. It doesn't count. I'm just like messing around with these BS exercises. You know what I mean? What a joke I am. Like my self-value is directly linked to my bench press max. That I used to be like that. But anyway, like it'd take a while, right? Because my shoulder would get bummed, my back would hurt. Like, well, I'm gonna do it anyway. I'm not actually working out unless I do these things. I had to redefine what my workout was. There was a dude, like, we have to be careful what we see on Instagram for sure, influencers and Instagram experts or whatever. There are some solid sources out there, in my opinion. We just got to, pick and choose and be discretionary. But there's this guy I saw in there. He said he's a dad. He's, like, in his gym working out, and he's front squatting, like, 95 pounds. And he's muscular, and he's like, I'm never going to front squat more than 95. I don't need to. Yeah. Like, I don't want to. Like, my goal is to just be able to keep up with my kids and run and play and not be hobbling around and in pain. Yeah. It just depends what your goals are. Some people are like, I want to run a 10K. I want to run 5 10Ks this year, like totally different. The boat that I'm in, like, of course, I want to be able to work out. I want to feel confident. My physique plays a role with my confidence for sure. I want to feel strong. I want to be a good role model for my kids, a symbol of discipline and hard work and effort, and motivate my kids, have my kids be proud of me, have my wife be proud of me, be all those examples for my wife too, and working out is a part of that. So me only, doing simple elliptical or assault by workouts won't get me there. So I do want to do some other things, but that's my goal.
Yeah.
But at the bottom line, and this is what we hear from almost every patient that we see, I just don't want to hurt anymore. We can get there, and then we can progress. But there's a reason why you're hurting. The other podcast I was talking about, like, there is a solution for musculoskeletal stuff. Dude, there is a solution. Things don't hurt for no reason. And if we rule out red flags and underlying sinister pathologies that maybe we're missing, and you're inherently a healthier person, you don't have a ton of comorbidities, you're not smoking and drinking a ton, this should get better. Things don't hurt for no reason. There's a reason why it's hurting. If it's musculoskeletal, like joint pain, right? We just have to figure it out, right? But anyway, so that's awesome. So for me, like, yeah, it's just my humble perspective and the way I look at stuff. I really respected that dude who's like, I don't need to squat more than 95 pounds. Right. My value in my life doesn't depend on my my front rack max. You know what I'm saying? I don't care what you think. Like, if it's like I go to a gym or something like that, or like, you're not as much of a man because you don't work out as hard as I do. Yeah. Congrats. I don't care. You don't
have 2 plates on the bar.
Yeah, exactly. but there is still a competitive version of me where it's like, I want to look good. I want to be confident in physique and stuff. For sure. It's just something I got to battle and just weigh out your pros and cons and your goals. You know what I'm saying? But anyway, that's yeah.
I love it.
Look, I think there's no doubt that we can keep you here for 4 hours.
It's already been an hour or more.
Yeah, I mean, we have tons of questions just because we've lived a lot of the things that that you talk about. We've seen it from the inside, so we have a really simple, direct correlation with an understanding of everything that you preach and you practice. So with that in mind, I think that a few takeaways that we've gained today for the guests who are listening are, it's never too late to start. Right. You have the ability at any point to kind of take that step forward and start to go through rehabilitation in any way that seems fit for you. Right. And then also that there's certain things that, like James brought up earlier, where there's maybe easier like DIY or at-home resources that you could gain because your shoulder hurts. But I think that everyone has to look at things from a deeper level. Because your shoulder hurting, it may be that fire alarm. Yeah. It may not be the core problem that you're dealing with.
Yeah, it's usually not.
And in many cases, it's not. Right. So seeking guidance from a professional or someone who understands the physiology of the human body in a deeper fashion could lead to a faster recovery process, because it might not be the fire alarm that you, for the last 6 years, have been trying to make quiet with that pillow.
Yeah,
right?
Exactly.
So seeking the correct guidance is really important from someone who's a professional.
Yeah, and at least get some concrete answers.
Exactly. And you know what?
People want closure. They want some closure.
Yeah. And a really good place to start is by going to Kyle's podcast that he has online, the Driven Athlete podcast, where he talks about an overwhelming amount of areas that are common areas for problems and issues, and he brings guests on to talk about those different things from angles of high-grade professionals. I know you recently had, or that you're going to have, someone at an Olympic level.
Yeah, she just came in last week. And then I had a pro tennis player on a couple months ago, and then I have D1 football players coming in next week.
So, I mean, so from high-grade athleticism to general activities like posture and, that office posture, sleeping posture, things like that. So tune into Kyle's podcast, because there's a wealth of information that you could gain on that podcast itself. Tons of different episodes, dozens and dozens of them.
I appreciate that. Yeah, thank you. One thing that I'm somewhat nerd out on, I think, is like the mental component, like the psychology of just performance in sports, but then also like for rehab and pain. Yeah. Pain science, that's a whole different subject that we get into, like with fellowship training and stuff. Yeah. And to pique your guys' interest real quick, Lil Wayne quote. This was the first thing they brought up in our training. Pain is an opinion.
Okay.
Pain is an output. It's not an input, which is totally interesting. Right? As an example, like real quick, like imagine someone gets like a shark attack. Someone gets their leg bit off or like their quad, like chunk. And at the time, they're like, I feel like something hit me. Right? What's this weird? Right? They're like, that was aggressive and doesn't like hurt.
Right.
And then they look down, their quad's missing, and they're like, F.
Yeah.
Then things kick in. Right? It's just interesting.
I
Well,
can
I'm gonna
tell you
go-
straight up, I dislocated my arm.
Oh, yeah?
Put my arm down, doing a punt return. I got up. Everything's fine, but everyone's looking at me, and I'm like, why? And I look down, and I see that my arm is over here, and that's
Yeah.
when it all hit me.
Yeah,
So the
totally.
shark attack thing, same.
Yeah.
I did that with my fingers.
Yeah.
Oh yeah. But anyway, those are super aggressive examples. But like, it's just to demonstrate we can't separate the mind from the body, and
Right.
ultimately, pain. It's been proved. Like, it is a thing. Pain is an output. It's not an input. Just saying.
Or if you want to get more aggressive, pain is a weakness. Is weakness leaving the body?
Pain's weakly. Yeah.
Another one.
Is that Denzel from Remember the Titans? Is that what you said? No, water makes you weak.
Yeah,
That's
water
it.
weak, yeah.
What a miss.
Great
Awesome.
movie. Man. Every football season, like late August, I watch that movie just to get ready, for football season. Just to get hyped up,
Well, now I'm going to think about the 75-year-old lady who had basically bone on bone and had no pain. I'm going to be like, well, she had no pain, Kyle said. So
Yeah, Kyle said.
Kyle said she was good.
Dr. Kyle.
Yeah, exactly. Oh God.
Awesome. Well, thank you for being on today. We really appreciate it.
Yeah,
man.
totally, man. Thanks for the invite
Yeah.
and the shout outs and stuff. And definitely, if y'all have any questions, like if you have any questions at home, y'all can reach out to us. Our phone number is 561-899-8725. If you live, we actually just had a phone call with a dude in Poland, by the way.
Wow.
Nice.
Yeah. So we do consults, we can chat at least to get some answers. Or our email, which is team@athleterc.com. Those are great ways to reach out to us, but we're always open to questions and guidance and stuff like that. If we feel like we're a good fit, and then conflicting opinions and suggestions and comments, podcast ideas, like we're always open to discussion.
Awesome.
Yeah,
and,
yeah.
and even at the least, drop a comment in the thread here and reach out. We'll make sure that you get past Kyle's information in the event that you're seeking some questions or some answers.
Yeah, I appreciate that.
Awesome. Well, thank you.
Thank you, Kyle.
Thank you.
Thank you.
Very good.
We could have kept you here
It's
forever.
weird being on the other side.
Yeah, I know. But it's good